lecture today is about class 1 malocclusion. So in this lecture we will discuss the definition, etiology and the management of this kind of malocclusion. So class 1 malocclusion or class 1 incisor relationship, when the lower incisal edge is located or occluded below the cingulum plateau of the upper incisors. Cingulum plateau is where the cingulum becomes to be straight. So basically here is the cingulum plateau, it becomes straight, which almost always in the middle third of the upper incisors. And this definition is according to the British Standard Institute. However, don't get that confused with the American way of defining malocclusion, in which they use the molar relationship, which is Engel's classification of the malocclusion, where the mesobuccal cusp of the upper six occlude in the buccal groove of the lower and the anterior groove, or the mesobuccal groove of the lower six. That's we call it Engel's class 1. So what is the etiology of class 1 malocclusion? When you say class 1, the incisor relationship is normal. So what is the abnormality about this kind of malocclusion? So let's see about the skeletal, soft tissue and dental / local factor. It's always there. It's always like this when you discuss the etiology of a malocclusion. So start with the skeletal factor. Again, we're going to look at the anteroposterior, vertical and transverse. Starting with the anteroposterior, here as you can see the patient has a class 1 incisor relationship. Chief complaint is crowd spacing between the teeth. And as you can see that the skeletal relationship is class 1, which makes sense. So the only problem with this patient is that, or the only issue is that the spacing between the front teeth. However, some patients might have a class 2 skeletal relationship and the incisors are a class 1 due to the dentoalveolar compensation. So the teeth will help us. But this does usually happen when we have a mild skeletal relationship. So class 1 relationship of the usually happens with the class 1 skeletal, so everything is normal, and the abnormality is about local factor. Or in some cases we will have a class 2 skeletal relationship in which the incisors compensated by proclination of the lower and retroclination of the upper to correct the incisor relationship into class 1. By here the skeletal relationship will be a mild skeletal relationship. And again could be class 3, and the incisors here procline in the upper, retrocline in the lower, trying to compensate for the underlying skeletal discrepancy, and again it will be a mild skeletal discrepancy in this case. So what about the vertical relationship? Okay, with the class 1 incisors you can get increased lower facial height with anterior open bite, or you can get slightly reduced lower facial height with deep overbite. So both of them are possible. Just to mention here, when you have an anterior open bite, don't get confused, because incisor classification is an anteroposterior relationship. Open bite is a vertical one. So when you have a patient with open bite, all you need to do is to just pick up your probe and draw a line vertical from these lower incisors and see where the lower incisor edge hit the upper incisors. That's how we decide the incisor classification. Slightly deep overbite is possible as well with the class 1 malocclusion. What about transverse problem? Most of the time there will be no transverse problem. However, in some cases you might have a class 1 incisors, as you can see, and the maxilla is narrow and needs expansion. So these are something that we might see in a class 1 malocclusion. So that is about the skeletal factor. So what about the soft tissue? Generally speaking, in a class 1 malocclusion, soft tissue are our friends. They are not causing a problem, but they are trying to compensate for the problems actually. So when you have a class 2 skeletal relationship, the upper lip and the lower lip, they are trying to retrocline the upper incisor to reduce the overjet and to correct the incisor relationship. And in the same time, the tongue will try to procline the lower incisors to correct the incisor relationship. So in general, the soft tissue in class 1 malocclusion are not really a good etiological factor of problem. They are more of helping us to do compensation. However, this is not the case when it comes to the bimaxillary proclination or bimaxillary protrusion. So in some cases, and one of the etiologies for the bimaxillary protrusion, that those patients will have a little bit of weaker lips. The force, they be having a thick lip, they don't have a high force, and the tongue will have a higher force that will result in proclining the upper and lower incisors. So as we said, soft tissue in most of the cases in a class 1, they are with the malocclusion, except when it comes for habit or to happen if we have a flaccid, thick upper lip, they are weaker, I mean as a force, and the tongue will push the incisors and causing proclination. Dental factor, and this is the main factor for the malocclusion, because if you think about it, these patients usually they have incisor class 1, and the skeletal relationship, it's either a class 1 or very mild minimally class 2 or a class 3. So usually the cause of patient seeking treatment when they have a class 1 is the local factor. That could be spacing between the front teeth, that could be crowding in the upper and lower arch, and the crowding is the most common cause. So what is the management? How are we going to manage patient with class 1 malocclusion? The first example is crowding. So whenever we have a patient with crowding and seeking orthodontic treatment, and this is kind of the most common cause of patient seeking treatment, we need to relieve this crowding. However, as we talk in the treatment planning lecture, the treatment of the crowding should not result in converting the patient into bimaxillary proclination. Meaning, if you want to provide space to relieve this crowding, you should make sure that you will not push the incisors too much forward to the point that the patient will be a bimaxillary protrusion. So, if you look at this patient here, I would say she's class 1 skeletal relationship. Some of you might say that no, she has a little bit of weak maxilla, maybe she's a mild class 3, it's fine. But if you get intraorally, you can see she has a class 1 incisor relationship, but she has a midline shift, she has an ectopic eruption of the canine, and crowding of the canine on the other side, which is severe crowding in the upper, and this 5 was extracted here, the 4, sorry, and it was completely outside the line of the arch, and this 5 in the other side is lingually displaced as well. So she has a severe crowding in the upper and lower arches. When we have a severe crowding, extraction is the treatment of choice, because extraction is not going to affect the patient's profile. All we're going to do is to take out teeth and replace it with the crowded teeth, so the AB position of the upper incisors will not be affected. However, if we decided to treat such a case without extraction, that means you will push the incisors forward with a good amount, which might affect the soft tissue profile, periodontium, and of course stability. So if you look at the OPG of the lateral kerf, as well confirm the clinical examination, patient is having class 1 malocclusion, widths as well say class 1, a little bit of class 2ish actually, and the upper incisors are slightly proclined while the lower incisors are normal, so actually you can't procline them even more. Treatment of choice, extraction, relieve crowding, and the teeth are aligned. Another option is, again, here you can see this patient anterior-posteriorly. He has a mild class 2 skeletal relationship, but it's very mild. Looking intraorally, he has a mild crowding or moderate crowding in the upper and lower arches, which does not require taking out teeth. So he was treating in a non-extraction case, and the teeth are proclined in the upper and lower, and for sure a bonded retainer is provided. So crowding with a class 1 malocclusion, you just need to relieve crowding. Now, this one will become more difficult if the patient has underlying skeletal discrepancy. For example, if he has a class 2 malocclusion, this will be the topic of the next lecture, because now you need a space to relieve the crowding and to correct the discrepancy. So in a class 1 cases, relatively it's easier because all the space you need only to relieve the crowding. While if you have a class 2 case, you need this space to relieve the crowding and to correct the skeletal discrepancy, and here is your demand for the space will be increased. The other example of local factor or the why patient seeking treatment is crossbite. Now, we will not discuss crossbite here in detail. We're just gonna discuss them quickly. We'll have a separate lecture for a crossbite. However, crossbite could be anterior crossbite or posterior crossbite. So anterior crossbite usually involve 1 or 2 teeth, as we can see here. Now, if the crossbite is involving 1 or 2 teeth, that usually is caused by crowding, because this tooth now, it does not have a space to erupt. So what's going to happen is going to go and erupt palatally. Sometimes the etiology for this crossbite is the location of the tooth pod of this lateral incisors that is more into palatal position. Treatment plan usually is to create space for this tooth and move it forward. That if the patient in the mixed dentition, that can be done by 2x4 this appliance, as you can see here, or removable appliance, or if the patient is undergoing orthodontic treatment, that can be done by a complete fixed appliance. Now, if the anterior crossbite is limited to 1 or 2 teeth, that usually the cause is local crowding position of the tooth germ. But if the teeth that are in crossbite are all the incisors, that means that there is more of a skeletal element of this malocclusion. All of them or 3 of them, that's going to tell you that okay, there's something skeletal here with this anterior crossbite, and this will be discussed in details when we discuss interceptive treatment of class 3 malocclusion. Unilateral buccal crossbite with displacement. Now, I would like to describe the crossbite correctly in the clinic. So if you have a patient like this in the top, and you can see that the midlines are coincident. Now the patient is biting cusp to cusp. He's not feeling comfortable. He needs to achieve maximum intercuspation, cusp-fossa relationship. So what he does is he shifts the mandible to one side. We call this unilateral because it's only one side. Buccal, or remember our reference is always the lower arch, not the upper arch. So in the mesobuccal or the buccal cusp, the buccal cusp of the lower, including buccal to the buccal cusp of the upper, that means that we have a buccal crossbite. So when the teeth bite cusp to cusp and then displace the mandible, we call it unilateral buccal crossbite with displacement. This video will help us to understand it even more. If you can see here, the patient bite cusp to cusp and then he trying to achieve maximum intercuspation and he shift the mandible to one side to achieve buccal cusp-fossa relationship between the teeth. As you can see, before the displacement, the midlines are coincident. Then when he's doing the displacement, the midlines are not coincident anymore. So it's causing a midline shift. Now, if the midline is not corrected from the beginning, that means that, sorry, I have to go back. So if the midline is correct from the beginning, displacement will cause a midline shift. But if the midline is not correct from the beginning, it's going to get worse if the displacement is toward the same side of the shift, or it's going to improve if, for example, the displacement is in the opposite side of the midline shift. So usually treatment involves expansion on both sides, right and left, because although we have the crossbite on one side, but then remember that this is not the case. The patient is biting cusp to cusp, all right, and then he's displacing the mandible to one side. So what we need to do is to do expansion for both sides. As you can see here, the patient is doing cusp to cusp, displacing the mandible to one side, midline is slightly shifted. We need to do expansion on this side and this side to correct the crossbite. Just remember, whenever we do expansion, the palatal cusp will be hanging down, causing reduction of the overbite because we're doing tipping movement. When we will discuss the crossbite correction, we will discuss how can we manage this problem. How can we correct the posterior crossbite as well? We can use quad helix, which is a fixed appliance, as you can see, with 4 helices to do the expansion. Or we can use a removable appliance where the expansion screw is there and the patient having the screw to open these ones. or we can use the arch wires together with the cross elastics, where the cross elastics goes from the lingual side of the upper to the buccal side of the lower. And here I'm just going to stop to talk a little bit of the cross elastics. Just remember that now we have two vectors of the force when we are using cross elastics. The first vector is the horizontal vector moving these teeth buccally and moving these teeth, which is the lower teeth, lingually. In the same time, we have an extrusive forces causing extrusion of the upper teeth and extrusion of the lower teeth. So number one, if I wanted these teeth to tip more buccally, while this one to move bodily, what I can do is using a round wire in the upper and a rectangular wire in the lower. By that, here is only bodily movement, while here is a tipping movement, which we know is easier, so we get these teeth tipped. However, that will result in a more hanging down of the palatal cusp, nothing for free. If you don't want that to happen, then we do a rectangular wire in the upper, a rectangular wire in the lower. We get more of a bodily movement here, bodily movement here. We get a better control of the palatal cusp in the upper and the buccal cusp in the lower. It depends on what are your treatment aims. So what about the extrusive forces? Now we have an extrusive forces from these elastics. So if you're using this cross elastics in a light wires like a 014 or 018 tie wires, definitely then there will result in extrusion of these molars. To avoid this extrusion, you need to go to a more of a rigid stainless steel arch wires. Sometimes we have a unilateral buccal crossbite but without a displacement, as you can see here. Now if we don't have a displacement, that means that we need to do all the expansion on one side. We can't do expansion here and expansion here. Now remember that quad helix and the URA, they work by reciprocal anchorage, which means if you push from this side, you have a reactionary force from the other side causing expansion here. So you need to be careful whenever it comes to a unilateral buccal crossbite without displacement. So how to correct this crossbite? It's again using here another example of unilateral buccal crossbite without displacement, using cross elastics and the arch wires, because that will not result in a effect on the other side. What about if we have bilateral buccal crossbite? Usually and generally speaking, when we have a bilateral crossbite, it's unlikely to have a displacement because the teeth are in a good cusp to fossa relationship. However, sometimes we might have a little bit of interferences that patient have a little bit of displacement, not too much. You just need to check that. However, if the patient has a bilateral crossbite, we usually don't prefer to fix this bilateral crossbite, and the reason for that, usually this bilateral means that there is skeletal element here and we need to do a skeletal expansion either with a skeletal with the RME or with Marby to do a bony expansion, which will be discussed again more details next lecture or the lecture after when we discuss crossbite. But the thing is, when you correct a crossbite that is bilateral, the issue that we are worried about, that this one is not fairly stable, and we know that. So then you worried that the patient will not wear his retainer, then the maxilla will be slightly constricted. The teeth will not go back to where we started. Instead, they will go back to be in a cusp-to-cusp relationship, where the patient will displace the mandible to achieve maximum intercuspation. So that might have put the patient into risk of starting as a bilateral buccal crossbite without any displacement, complete correction of the crossbite, relapse take place, partial relapse, not full relapse. The patient will have unilateral buccal crossbite with displacement, which is worse. So that's why we need to be careful when we decide to correct a bilateral crossbite. As I mentioned, this kind of crossbite is usually corrected using RME or Marby appliance. Again, we might have as well lingual crossbite, and remember, as we said, the reference is always the lower. So here is the lower buccal cusp is including lingual or palatal to the palatal cusp of the upper molar, which means that we call it lingual crossbite or scissor bite. Teeth can involve more than one tooth. So how to treat this one? You need to do expansion of the lower arch, slight constriction in the upper arch using the arch wires. You can support this with the cross elastics, but this time you use it the other way around between the buccal of the lip of the upper and lingual of the lower to uprighten the teeth. Remember, whenever you use any method of correction for the crossbite, you need to free the occlusion to allow the teeth to expand. So we have done now the crossbite. What else with the class 1? We might have an impacted or unerupted teeth. One of the examples, as you can see in this case, class impacted canine, where you need to do exposure of the canine, opening space and alignment of the canine. Could be as well impacted central incisors with class 1 malocclusion. As you can see in this patient, supernumerary prevented the eruption of the central incisor. Had to take out 2 teeth, premolars. Here is an impacted central incisor, and then we open a space for that one to allow the tooth to come down in its place. So impaction can be part of class 1 malocclusion. We will again discuss impaction with the canine and the central incisors in details in a separate lecture. And here is bringing the tooth down into its position. Median diastema. It's defined as the space between the upper central incisors. Median diastema can happen in a class 1 malocclusion or any other malocclusion, but usually we discuss it with class 1 malocclusion, and here we will discuss it in detail to finish the topic of the median diastema. So what is the etiology of the median diastema? Why do we have median diastema? The first one is what we call it the physiological diastema, which basically the diastema we have during the mixed dentition during the eruption of the canine. The canine will be pushing against the roots of the lateral incisors, causing them to flare, and the central incisor will have more space, so they will flare as well, causing median diastema. At this stage, any treatment is not necessary, because these canines will go down and the roots of the lateral incisor will be uprighted spontaneously, and there will be no need for any orthodontic treatment. The second cause is congenitally missing lateral incisors. So whenever we have a missing lateral incisor, we have more space, the teeth will move and open a median diastema. As well, as you can see here, usually hypodontia associated with microdontia. So if you have a microdontia, again, we might have a median diastema. Enlarged or malposed upper frenal labial frenum. So if the frenum is thick and well developed, that can cause a median diastema. How to diagnose a high frenal attachment? What you need to do is to do the blanching test. So basically you stretch, as you can see here in the picture, you stretch this labial frenum, and you should see the blanching going from the labial surface into the palatal surface, the incisive papillae area. That means that the frenum is going from the labial surface into the labial side into the midline or the palatal side of the palate. So you should do the blanching test whenever you diagnose a high frenal attachment. As well, taking a periapical, because some of these cases they might have failure of fusion of the bone in the anterior maxilla. So as you can see, we have like a clefting of the bone, which will make closure of the diastema a little bit more difficult, so you need to diagnose this from the beginning. Other cause of the median diastema, supernumerary tooth, and we know that the common type of the supernumerary that does not cause impaction is conical, which basically does not erupt but sometimes can cause displacement. So if we have a supernumerary in this area, these teeth will not meet, so we'll have a median diastema. So whenever you have a median diastema, you always have to exclude the presence of a supernumerary. Small teeth, as we said earlier, microdontia will result in you have more spaces, so then you get a diastema. And the last one is proclined incisors. So if your incisors are proclined, which means that they get more space. So if they get more space, then that means that we might have this space located between the two central incisors, and we have a median diastema. So what is the management? How do we manage median diastema? It depends first on the etiology of the problem. So what is the cause? And here we do the management. So the first one is the enlarged or malposed supernumerary upper labial frenum. As we can see, this one is taken from Prophet textbook. You can see here high frenal attachment, and we have a median diastema. And don't forget to diagnose the high frenal attachment by doing the blanching test and taking a periapical radiograph. Now, one of the proposed treatment for this median diastema is to do frenectomy and do space closure to correct this median diastema and finish the treatment. So where did all this frenectomy things came from? Why the frenectomy was introduced into the management of median diastema? It's all based on the work that was done by Edward in 1976. Edward did a huge amount of work on CSF and frenectomy, and he was the guy behind all of this work. So what did he do? He did a study from 3 parts. The first part, it was an investigation of the sample to see what is the relationship between having a prominent frenum and high frenal attachment and having diastema. Meaning, does everyone with a high frenal attachment or prominent frenum will have a median diastema? Then the second part of the study was the stability of the median diastema. So what he did, actually, he got these patients, he closed the median diastema for them using fixed appliance, then he took the wire off and sent the patient home with the braces there to see the relapse of the median diastema. And that was the second part of his study. Then the people who relapsed, he go, okay, the braces is there, just do the spacer closure again. So he did spacer closure again, and then he did a frenectomy to those patients. And again, he sent the patients home without the wire to see, and without a retainer, to see how the frenectomy will affect the stability. Meaning, if the patient before he took the braces or the wire off, they will relapse. And then if he does a frenectomy, and it doesn't relapse, it means that the frenectomy will improve stability of a median diastema correction. So in the first study, what did he found? First part of the study, he found that 70% of the sample who have median diastema, they had an abnormal frenum. So abnormal frenum was responsible for 70% of the median diastema sample, which is a huge number. However, abnormal frenum with no diastema was seen in 20% of the cases, meaning normal patient who does not have a median diastema, 20% of them, they have a high frenal attachment. What does that mean? It means here that there is a higher concordance or higher incidence that when a patient has a high frenal attachment, he will have a median diastema. It's 70%. However, that's not necessary, because in 20% of the cases, they have a higher frenal attachment or a prominent frenum, but they don't have a median diastema. In the second part of the study, he found that 91% of the median diastema with abnormal frenum relapse. So, for example, let's assume that he did a 100 treatment of median diastema and they have an abnormal frenum. In 91 patient, the median diastema reopened, which means the high relapse. However, if the median diastema was not associated with the frenal attachment, the relapse was only 9% of the cases. So from these numbers, you can say that high frenal attachment, it increased the risk of relapse by 10 times, from 9% up to 91. So what did he found in the third part? That the relapse of 90% before frenectomy for this sample is reduced to 20% after the frenectomy. So these 90% who had a abnormal frenum and they have a relapse of the median diastema, he did a frenectomy for them, and 20% only relapse, and 80% did not relapse, which means that there is a reduction from 90% of relapse into 20% of relapse, which is a huge reduction and reduced reduction in this relapse and improvement in the stability. So from this work, we can conclude that frenectomy, high frenal attachment, plays a major role in causing the median diastema and causing relapse of the median diastema, and it will need to be removed in order to achieve more stable results. So the question is when to do the frenectomy. Now, when first frenectomy was introduced, some clinicians say, okay, do frenectomy before the space closure. So you remove the frenum, you allow the teeth to move and close the median diastema. And what happens is when you remove the frenum, there will be a scar tissue after the surgery, which will prevent the spontaneous closure of this median diastema, and it will make the space closure of the median diastema later on more difficult. Okay, let's then do space closure completely and then do the surgery. And here become a problem with the surgeon. As you know, if you need to do frenectomy, it's not like you need just to do the laser and take the frenum here. That's not a frenectomy. You need to open up a flap, go between the roots, soft tissue, fibrous tissue that is going into the bone, and you have to remove it. This is a frenectomy. So there is a risk always if you close the median diastema that this soft tissue and this high frenum, and when you remove it, you might hit the roots of the central incisor. So what we can do is to do partial closure of the diastema, that only 1 or 2 millimeter left, send the patient for surgery, remove the frenum, and then continue the space closure. After that, you will have a scar tissue that will hold the teeth together, will improve the stability. That is the recommendation to do frenectomy now. If the surgeon is comfortable doing the surgery after you do the space closure, it's better. So this is again the case from Prophet textbook. I want you to notice here something, that this patient, median diastema, was closed, frenectomy was done, but what? Bonded retainer is still placed. So why is that? Because according to the evidence, it will reduce the relapse from 90% into 20%. But we still have 20%, which means 1 out of 5 patients of median diastema will relapse. So you need to provide the patient with a bonded retainer. So someone might ask here, why to do the surgery at all if we're going to go for a bonded retainer anyway? And that is the shift in the way of thinking. When Edward first proposed the frenectomy, at that time, bonded retainer was not as popular as the bonded retainer with all the bonding technique as this time. So patient usually used to have a holy retainer. So for that reason, you need to improve the stability. But now, because anyway, we will go for a bonded retainer, in my opinion, frenectomy is not as needed as we used to do it before. Again, from my personal experience, you go for a frenectomy only if you think that you can't do the space closure due to the really thick frenum, or if you do a space closure, the frenum will be collected in this area, and the appearance of it will not be pleasant for the patient, and then we need to do frenectomy. I just want to tell you that when we talk about a prominent frenum, it is the literature here and what Edward did, it is really prominent frenum, especially in the Afro-American. That's really a thick frenum, not like the high frenum that we have it in our population. So the recommendation for frenectomy is to go for space closure. If you manage to close the space without the need for frenectomy, and the patient is happy with the appearance, then just do a bonded retainer and that's it. If the patient is not happy with the appearance, you can do frenectomy, or if you think that the frenum is too thick that you can't close the space with the presence of this thick frenum, then frenectomy is recommended. If the cause of the median diastema is a physiological diastema, as you know, we just wait and see, because this one will be spontaneously corrected once the canine is going down. And actually, even if the patient insists on treatment, we can do nothing for him, simply because if you upright this canine, this lateral incisor, the crown will go mesially while the root will go distally, hitting the crown of the canine. So in this stage, we just have to wait and see. And congenitally missing lateral incisor, again, the treatment plan is either to space closure and make the canine replacing the lateral, or space opening and place an implant. If we have a supernumerary, you just need to take this supernumerary out and do fixed appliance to close the spaces. If you have a small teeth, you have to decide whether to do space closure, and now you will have a Bolton discrepancy because you have a smaller teeth, so you will not have a perfect class 1 on the buccal segment. You can have a compromised occlusal relationship, or you decide to redistribute the space, for example, closing the space between the centrals and building up the lateral, because as you know, most common cause or the most common tooth to have size discrepancy is the lateral incisor. Sometimes it's small, sometimes it's normal size, so usually it's this tooth that's causing the problem. If you have a broke-lined incisor, retracting these, because when you have a broke-lined incisor, it means that the incisors are moving to a bigger space. So if the teeth are well aligned and you move the incisor into bigger space, you will have spacing, and this space can be between the two incisors and causing median diastema. If the cause is a broke-lined incisor, simply you just need to retrocline these incisors. And thank you very much.